Thank you, Martin. Hi, everyone. My name is Simon Wasserback. I'm a clinical psychologist in Lille, very north of France. And I'm also working for the WHO Collaborating Center for Research and Training in Mental Health. I'll let my colleague introduce himself.
Laurent de Fromont, I'm a psychiatrist and head manager of the organization we will show you.
So, thank you all to be here. Thank you to Martin and his team and colleagues for their energy, the trumpet playing, the guitar playing, maybe another instrument playing, I don't know, we'll see. As you can see, we are at the very north of France, after our colleagues of Marseille, who are at the very south of our country. But you'll see that we have some common ideas, common ground. You'll see some words like recovery, human rights, empowerment, and I'm really happy to see and hear other colleagues using those words. Quickly, what's psychiatry in France is moving since the 60s. We have sectors, what we call sectors. It means that we have a geographical area, a catchment area, we are working in. If you live in one street, you will be in contact with this team, but maybe if you live like 500 meters next to that, you will be with another team. So that's one point. Since 1986, the global budget, it means that for, okay, I can see it. The same team is same budget for the team in the hospital and in the city. So it means that you can use your budget inside your sector as you wish. You can put everyone inside the walls of the hospital, or maybe outside, hopefully. And now for 2018, we are already 2020, of course. We have some data around 95 beds for 100,000 inhabitants, but it can be very different as we will present it to you. 24 psychiatrists for 100,000 inhabitants, and 12 of them are from the private sector, but paid by the social security. So those numbers are important because sometimes when we are talking about France, we know that we have money compared to other countries. We have a lot of professionals. We are working with at the international level, and some countries have the same numbers of professionals that we have for one sector. So we have to keep this in mind, of course. But then during the years, we have a lot of development, a lot of new ideas like the mental health support groups, the local mental health councils, and we will show you in details after. About our sector, as I told you, we are the 59G21 sector. That's our name. 59 is because we are in the North department, 21 because we are the 21st sector of this department. In 1975, it was an asylum, a true asylum. Everyone was put inside the walls. All the pavilions were closed. All the patients were hospitalized without consent. 300 beds, 565 hospitalization per year, and 99% of the staff in the hospital. So that's how the journey starts, but things are moving. Now, we call it the Lille experience, but it's specific to our sector, even if other sectors are also working this way. We can give you some important date for us since the 2002. We worked with short-term family care services. 2005, a mobile team specialized for intensive care in the community. 2008, self-help groups. 2010, local mental health council. 2012, peer support workers as professional in the service. They are colleagues. 2014, the development of the recovery approach with training, with Congress. It's important, this date, because as you can see, it's not so old. And we have, every professional of the service have to train themselves about this recovery approach, because it's not, for the moment, very present in the training of the professionals. So it's more field training.
It's not very common in France. It came, I think, also from Marseille, with the arriving of working for, housing first. I think in France it's one of the big movement of the recovery approach.
And we are still working on maybe trying to be creative. And in 2015, we organized the election of spokesperson. It means that users from our sector are elected by other users, and they are representing them inside our organizational meetings, for example, and they do also other things. And 2017, training of professional by expert of experience, which means that associations and users come and make training and presentation to the professionals. So, our catchment area, we are in the very north of France, we are very next to Lille, and we have 6 municipalities in the east of Lille, not a very big territory, with 88,000 inhabitants in a urban zone. And some numbers, again, the number of inhabitants, so more than 85,000 now. And we have, in 2018, the last data, 3,500 persons in care. Do you want to add something on it?
This is to say that there's a lot of people who need help for mental health. It's a very common problem in the population. And when you look at the numbers that are shown by epidemiology, you can see that lots of people could have some care, some medical or some psychologist care. Even for the problem of suicidal risk, it's almost for when we ask people in the street if they have suicidal thoughts, it's for in the instant, it's the same numbers of people that have a contact with mental health for us. Then it's a very big problem, and it can't only be managed by mental health itself. In France, maybe sometimes we think every problem, every mental health should be sent to the organization, the health organization. And we do think that the problem is not about the numbers of psychiatrists or psychologists, but it's a global problem for the whole citizenship. Because as we show it precedently, the need of care, we don't know really what is the need of care, because it's a health standards, and we can't see people who should be helped. But we can show, we can see the demand of care. and how people get to care, to have some help, and how they act, what we can give to them. There's three determinants for access to care. Access to care is very important because it's for most of the psychiatrists the way of decreasing the disability. Then social representation, we have a big problem with that, with stigma. People don't get to care. And the network, what I mean by networks, it's all the interaction between people with their friends, with socials, with primary care, that will say you should go to have some help. And also what we maybe don't integrate so much is that our practices, our medical practices, or the health organization have a big impact on the way the people will get some help. And that's why we say that we have three problems. It's not really a medical problem. It's a global problem for citizens. It's a social representation. What is being or having a problem or having a disease. And the second is about democracy and what in France we call that health democracy. How people, how elected people can have force an impact on the organization, on the medical organization. And the third thing is how, as a practitioner, as doctors, we organize the care to make this acceptable for people.
So about the health, what we call the health democracy, the idea is to be included, integrated in a territory, organization for health, for mental health, and for citizenship. You will see that those terms, we always link them because we think that you cannot take just one and separate it from the others. And also about the participation of service users. And we will give you some examples of what we are trying to do. First, the local mental health council. Concretely, it's like having a big table and having all the stakeholders around this table to be able to discuss about mental health and what it implies. It's not only psychiatry. Of course, there are psychiatrists and mental health professionals from the private and from the public sector. But when you are talking about mental health, you have to also imply the local actors, like the sanitary services, the social services, the housing services, of course, but also you can work with directly with the citizen, with the families, with the artists, and you have to gather everyone to be able to find solutions to very complex situations. How it works in France is that you have to work directly with the mayors of the cities, and one of the mayors is acting as the chair of the associations. And then, when you have everyone, you can discuss, and again, you have to work on inside your territory, because it allows you to know who you can contact if you have a certain kind of problem. So, no decision regarding services creation and care organization in the city without the inhabitants or without consulting inhabitants. So local elected and citizens' involvement in the local health and social policies application. So that's a concrete example giving health thinking vision on the territory. Then other details on the local mental health council. It's about coordination, and you can create tools regarding your territory and as I said, the complex situation of the specific problems you have in your territory. What I can also tell is that in France now there are more than 200 of those councils. The scale of the councils may vary. For example, in Paris it's one council for one part of the city. In our territory it's for 6 cities. But you have to be able to know, to have the good scale to be efficient. And the council are also working on prevention, on mental health prevention, on information. Often they are working, we have in France what we call the mental health weeks information. It's 2 weeks in March, and we are trying to gather everyone in the general population, make them think about what is mental health, what you can do to promote mental health. And the local councils are very active on it. We also organize in this context well-being workshops. So it could be a workshop like today with one theme, and it's animated by professional, but also user, experts of experience, as we say. And we are discussing with the general population about what it is to having this kind of problem, but also what solutions can be found. The other interesting, I think, experience is our experience with spokespersons. I briefly mentioned it just before. We are working on it since 4 years now. We are at the 3rd election, just a few months ago. At first there were 4 spokespersons, now there are 6, because we propose a lot of things for them to do to help us. Of course, there are a link between the users and the professionals, and they are working on suggestion forms. It means that in every facilities of our sector, you can write your ideas, what is good, what is bad inside the service, and then we try to work on it and to find solutions and to give the information about the solutions we found about those problems. They also animate users forum, so it's a forum this time without professional, just between users to be able to discuss about mental health, about the sector, about the organization. What else could I say? And those spokespersons are involved in the organizational meetings of the service also, and they are kind of experts of our service, and they are really helpful in those meetings. So we also have in the service peer support workers. In France we have a training, specific training, 1-year training for those professionals. And what is important is this word. The peer support workers in our service are professional, they are colleagues, and they are working with us as other professionals, and they are part of the multidisciplinary team. We have the staff training by experts of experience from users and NGOs. The well-being workshops, I already told you about it. And we also have a group of reflection on the risks reduction and the restraints limitation. So to be able to achieve those objectives, to be honest, those objectives are very high. It has time, it has energy. If you remember the slide about the dates, you saw that this work has started decades ago, and we are still trying to push things forward, but we cannot do it by ourselves. We, of course, need the field actors and the field associations. We have, so we name it because it's important for us, the mutual support groups, Amitié Partage and Ch'ti Bonheur, but also NGOs like Étoile Bipolaire, Alcoolique Anonyme. We have the Hearing Voicers network, and we also have the family associations. To conclude this part, two other tools we used and we had to create. This is the recovery charter. It's specific to our sector. As you can see, we have 10 or more IDs to support this charter. And what is important is also the signatures. The head of the service signed it, so some professional, but also the director of our hospital, and at the very right of the charter, the spokespersons who were involved in the writing and in the dissemination of this charter. And maybe you heard of it, we also use the WHO Quality Rights program in our sector. This is a slide with some results, but also the recommendation, because as I said, and you know the idea that recovery is a journey. We still have a lot of things to do. It's often about systematizing our ID, because we are trying to implement things, but between the start of the ID and being sure that this ID is really systematized in the system, it takes time and energy also. So we could discuss it, but it's one of the tools we use to be able to discuss, to train the professionals, to exchange with the users, and also the elected representatives and all the stakeholders.
Then the big action is to make our care acceptable for people. And the start is to make most of our team out of the wards. 76% of our team is in the city. All very different professionals that are in the community. That's the start of this possible organization. For every call, we can respond in 48 hours. Every people who need help receive an answer in this delay. And we have a model of evaluation with people to give rapidly an answer if you need some help. How many, is it an emergency or not? What would you do? And for our small territory, we can receive 1,200 new care demands a year. Then it's a whole organization, global organization that needs to think the way of care very differently, without waiting list, and an organization that first look at what are the needs of the people. And we also always think to be in touch with the general practitioner, because we think our job like a network that sometimes psychiatry forgot to maintain, because psychiatry used to take people and take care of them alone, and don't work with the others carers. And then it's necessary to have a constant link with the others. With this organization, we have the higher rate of the regional care, because we have 5 and 7% a year with all the people. All those people don't have high needs of care, but it can think about how we could be very tôt. Être tôt.
Too soon?
Soon, very soon, present if people need help. Then we also have an intensive care team, which can be available in emergency in the city. In most of the time, we stay with people about 15 days. And we have a early and a very high intervention on crisis. And the aim is to avoid every hospitalization. And we work with family, with all the people that are around the users. We think our job not just to take care of people that are in our beds or are with us, but of every people that are in the city. When we can be called by every member of every citizen to say there's someone who have problem, and we look with them if we should be there. We try to be there 20 hours a day in the city by using phone. People can ask us to anything at every time. It gives our hospitalization to reduce, and we just have 10 beds for our inhabitants. It's about 12 beds for
12 beds for 100,000 inhabitants, compared to the data I gave you in the previous slide of 95 beds in average in France.
And we aim no contention and no seclusion. We have one contention this last year for 3 hours. And the doors are open for every kind of people that will come sometimes against their will. That's our clinic. It's a small one, but we try to have a very good quality of for people that should come.
And maybe just, and in this facility we tried, I was talking about human rights, and we really think that it's important philosophy to have also. There is recovery, there is also human rights, and inside the hospitalization we are trying to promoting rights.
And the length of stay is 7 days. And we also be with people when they get out, and most of them never came in the hospital. But we have lots of proposal to make, and we stop to make day hospitalization, or we reduce what we could propose as activities. But we, as maybe the idea of working first, we are with people to think, what could you do? What could we help you to develop yourself? And we have teams that care of people with the most higher disability. It's a FACT team, flexible, assertive community treatment. It could be something like that. We have some houses, like I heard you have here. And people could have their own flats. How we could describe our organization. It's quite complex because it's very small parts of team with different goal. And the hospitalization is just a small part of it. We developed this assertive approach. It's to reach people, to get to them, and to see what kind of help they need. And to finish, I will show you that we didn't invent anything. We just get abroad and look what has been done, and took some ideas that we bring back with us and try to make it real for us. Thank you.
Thank you very much. Thank you, Simon.